Welcome to the EW Podcast. I'm your host, Eric White. Today's episode is a conversation with Dr. Edward Taub. Dr. Taub is a professor at the University of Alabama at Birmingham and a behavioral neuroscientist. He developed a family of techniques known as Constraint-Induced Movement Therapy, or CI therapy for short, that have been shown to be effective in improving the rehabilitation of movement after stroke, traumatic brain injury, cerebral palsy in young children, multiple sclerosis, and other neurological injuries. He has also developed a form that is efficacious in the treatment of post-stroke aphasia. I first read about Dr. Taub in the Dr. Norman Doidge book, The Brain That Changes Itself, and was honored to get to spend a little time chatting with Dr. Taub directly about his work. In this episode, we discuss the questions and experiments that led Dr. Taub and his colleagues to eventually create CI therapy, including how they applied what they learned from their experiments with monkeys to humans. We discuss the importance of patients continuing to seek improvements outside of therapy, the reasonable expectations and limitations of CI therapy, among other topics relating to this work. We finish the episode talking about meditation, and Dr. Taub shares a surprising story of how transcendental meditation improved his life. So a couple quick notes about this episode before we get into it. There are some sound issues that I just have to note going in. First, there is a background hum that is audible when Dr. Taub speaks. I've done my best to get rid of it, but I think most people will identify it right away. That being said, you'll likely adapt to it pretty quickly and forget it's even there after getting past the first 15 minutes or so. Additionally, it seems as though Dr. Taub was receiving some notifications on his computer while we spoke, and instead of stopping the interview to address it and taking up valuable time, I just rolled with it. So I just want to forecast that when you hear those notifications, the sound is coming from this podcast and not your pocket. If you'd like to learn more about Dr. Taub or know someone who might benefit from CI therapy, I have supplied more information in the show notes, including links to a few things we talk about here in this episode. And if you'd like to follow this podcast, you can do so by finding me on Instagram at the EW Podcast. So, without further ado, here is my conversation with Dr. Edward Taub. Thank you for joining me, Dr. Taub. I appreciate you taking the time to speak with me today about your work.
My pleasure.
So I will provide information on your background in the beginning of this show, but maybe you can just briefly describe your main focus as a researcher for the audience.
Well, I've been doing research for many years. And actually, I think it's probably fair to say that I've been doing the same experiment for decades, starting with monkeys and then going to human beings, starting with stroke and then going to a variety of other neurological conditions, then speech, and now most recently cognitive impairment. But I've been using the same techniques for the decades, and we now call it CI therapy, but we began the work with monkeys.
Did you, just to get a little background about yourself before we get into your work, did you always know you wanted to be a researcher? How did you get into the field of science?
Well, I got into science actually through philosophy. And as an undergraduate, I took philosophy courses, and I was enthralled by certain areas in philosophy, but became very dissatisfied with the fact that you could have arguments, both sides of a question. And if you got particularly good people arguing those sides, then they were equally plausible. This actually goes back to Socrates, who invented the profession of lawyers, where you adopt any position and you try and make it equally plausible and equally strong. And that was the case in philosophy. And it gave me an uneasy feeling at the pit of my stomach to feel that I would be spending my life arguing questions that had no empirical resolution. And it became clear that the portion of, or the discipline that enabled the disposition of philosophical questions was psychology. Because you could pose a question that might have philosophical import, like the nature of language, which at the time that I was an undergraduate was a very important issue in logical positivism. But people have been arguing about the nature of signs and symbols and different aspects of language for decades and without any resolution. And I thought, well, if I studied psychology, I would learn how to do experiments on the nature of language that would allow empirical answers to the questions that were being considered. Actually, I got into psychology, and then it's only about 6 or 7 years ago that I'm down working on language. I've been movement rather than on language, but that's how it all started.
So it started with questions of how the mind works, and it kind of led you into wanting to do actual experiments to gain empirical data to decipher how the mind works.
You could put it that way. That's okay in layman's terms.
Yeah, I'm a layman.
But I became a behavioral psychologist, and we don't talk about mind in behavioral psychology. We talk about behavior and behavioral tendencies, and that was enough for me. That was fine. That seemed to explain more than enough as far as I was concerned.
Okay.
Whatever it explained, you could grab a hold of it. It was real. It was empirical. It wasn't something that was non-material. And experiments are about material entities.
Excellent. So we'll get into, I would like to discuss with you the use of constraint-induced therapy, CI therapy, for things like aphasia, which obviously deals with language. But for now, let's just start with what diagnoses is CI therapy effective in treating?
Well, that's starting at the end of the story.
Okay.
Would you like me to start at the beginning of the story?
Let's start at the beginning. You're right.
Okay. Well, first, the long name of the therapy is Constraint-Induced Movement Therapy, which is descriptive, but it's a mouthful. So we abbreviate that to CI therapy. And in answer to your question, it is a family of therapies, not just one. Okay. So that we have at least 10 variants of it now. We began with monkeys after a certain kind of experimental lesion, and then moved on from there to human beings after stroke, then to human beings with MS, human beings after traumatic brain injury, after cerebral palsy, from 1 year old all the way throughout the age range of childhood up to adolescence and then to old age. We started with the arm. In rehabilitation, we call that the upper extremity. Now I can't think in terms of arms or legs. One's language gets corrupted by what one does. Well, I think in terms of upper and lower extremities. So we began with the upper extremity, and then we shifted then to the lower extremity, the leg, first after stroke, then MS, traumatic brain injury, TBI, and cerebral palsy, CP. But also after spinal cord injury and fractured hip. We moved on from there to speech after stroke, called aphasia. And most recently, we have begun using exactly the same techniques. Though in many of these variants, it looks very different. But basically, the procedures are the same, just modified for the subject matter. Have been working with cognitive impairment after, there's the cognitive impairment that occurs with aging, going from mild to moderate cognitive impairment, and from there to severe cognitive impairment or dementia and Alzheimer's disease. But you also have cognitive impairment associated with critical care, where a person is immobile for long periods of time in an ICU, an intensive care unit, frequently intubated for upper respiratory disorders like pneumonia and COVID-19. And people frequently come out with serious cognitive impairment. So that is going to become more and more frequent.
Right. And let's just kind of back up even more. Basically, the constraint CI therapy is the goal is to get the brain to learn to use a limb again, correct? So we're talking about things where the use of a limb has been unlearned. Is that correct?
Yes, it's been suppressed.
Mm-hmm. So what sort of questions were you asking at the beginning of your research that ultimately led you down the path of creating CI therapy?
Okay, that's a long story. Impressive, but it may be of interest to some. The story all began years ago with some basic research that I was doing with monkeys. And it turns out that in 1895, Sir Charles Sherrington, who many consider to be the father of neuroscience, did an experiment with Mott, a neurologist, Mott and Sherrington. And what they did is they surgically abolished all sensation from a monkey's forelimb, a single forelimb, leaving the motor innervation intact.
So can I just butt in here to put this into layman's terms to make sure I'm following you? So the monkey still had the capability, theoretically, to move its arm, but there was no feeling.
Yes.
Okay.
And let me explain that even so that it's more clear. So that's important. The spinal nerves come off the spinal cord in two routes. The root coming off the top of the spinal cord, or the part of the spinal cord facing back, the back, is called the dorsal root. And that contains sensory neurons. The ventral root coming off the front of the spinal cord, so that the part of the cord that you would see if the vertebral column wasn't there, if you look through the chest cavity, that off that part of the spinal cord comes the ventral root. And the ventral root is motor. So you've got the dorsal or sensory root and the motor or ventral root.
So this is sensation coming in, going through the dorsal, goes to the brain, the motor comes down through the ventral, which is the fronts,
Exactly.
back to the limb. Okay.
So if you sever the dorsal roots, you abolish sensation. But if you leave the ventral root alone, motor innervation is intact. And what Martin Sherrington, especially Sir Charles Sherrington, found, because he was the one who made a major theoretical statement about this, was that when you deafferent a single limb in monkeys, the monkeys never make use of that limb again. No matter how long the monkey lives, he doesn't use it to walk on. Monkeys are quadrupeds, they walk on 4 limbs. Doesn't use it to pick up food, to climb, to defend against a threatening object. No use. But the motor of innervation is intact. So Sherrington asked, why should that be? And he concluded quite reasonably that what he had done was abolish spinal reflexes. Now, spinal reflexes have an afferent portion or an afferent limb coming in over the dorsal root and a motor limb or motor fibers going out over the ventral root. And you see that in the knee tap, knee jerk reflex. But there are hundreds of spinal reflexes. And Sherrington concluded that what he had done is interrupt spinal reflexes. And therefore, the monkey didn't make voluntary use of the limb. Concluded from this that spinal reflexes were the basic building blocks that underlay the performance of voluntary movement. And that was called Sherringtonian reflexology. And it became the dominant position in neuroscience for the first 3/4 or more of the 20th century. It was not only a dominant position in neurophysiology, but also in behavioral psychology and in rehabilitation and in other sciences associated with movement. That had basically the status of an axiom. Then we came along, A.J. Berman, my colleagues, Harriet Knapp, and I. I'm a behavioral psychologist. And we asked, is it possible that through behavioral techniques, we could get a monkey to use a deafferented limb? We didn't really think that this would be possible. But intellectually, it was a possibility, and we thought that it ought to be evaluated experimentally. So we deafferented a series of rhesus monkeys. My colleague A.J. Berman was a neurosurgeon. And we then tried 2 simple behavioral techniques. First thing that we did was we restrained the intact limb. Now, just one forelimb has been deafferent, the other limb is intact. So we restrained that forelimb. And to our astonishment, well, certainly surprise, the monkey began using the deafferented limb.
So they had two arms that are still connected with the motor nerve.
Yes.
One has the sensory input, or I guess, yeah, sensory input. The other one does not.
Yes.
And by restraining the one that had both nerves intact, the monkey was then forced or
Yes.
began to use their one that was suspected they could not use anymore.
You said it. It forced to use the limb. We increased the motivation to use the deafferented limb. That is, because unless the monkey uses the deafferented limb, it couldn't pick up food objects and eat. It couldn't walk. It couldn't climb. It couldn't do anything. It was rendered helpless. This greatly increased the motivation to use the limb. The monkey used the limb.
Was that use of that limb immediate upon restraining the other limb, or did it take them time to realize that they could still use it? What's that? A few hours?
2 hours. Actually, they began moving it in a primitive fashion immediately. And within 2 hours, the use of the limb became quite sophisticated. It was clumsy. There was no sensation in the limb, but they could pick up small objects between thumb and forefinger.
How long had that limb been deafferented before you restrained the other limb?
Depends on the monkeys.
Okay.
Monkey. In some cases, for months. In some cases, for years. And they began using it within 2 hours. But if you remove the restraining device on the first day of restraint, they immediately reverted back to non-use of the deafferented limb. But if you left the restraint on for a week and then removed it, we didn't try intermediate periods of time. That would be interesting. If you left it on for a week, then the use of the deafferented limb became permanent for the rest of the animal's life.
Wow.
Now, the use was clumsy. It was not normal use, but it was very extensive. There was no single category of movement that had been abolished. Another technique that we used was training. We left the intact limb unrestrained, and we fasted the animal for 18 hours so it was hungry, and we made food reward contingent on his using the limb, like primitive flexion, then grasp of a water bulb that produced an automatic pressure wave, which was recorded. And then finally, we used a behavioral technique called shaping, where you require the organism, and shaping is used extensively with human beings in learning situations with children, with adults.
Is this Pavlov's dogs scenario? Is this a Pavlov's dogs type of scenario?
Skinner's animals, not Pavlov. This is operant conditioning.
Okay, yes.
Skinnerian conditioning, shaping.
My ignorance is showing a little bit here.
It isn't ignorance, it's lack of the information. And no reason why someone other than a specialist should have that information. But that's what I learned in graduate school. So the idea is, I thought that let's try it with the monkeys. And that worked like, what shall I say, gangbusters. And so what you do is you get an organism, a monkey or a human being, to make the best movement of which they're capable, their personal best. And then, in order to, with monkeys, to get food reward, you ask them to improve on it just a little bit. By what?
So you make the task a little more difficult? Is that?
Yes. And we call that a successive approximation. So let's say you have in mind that you'd like to train a monkey to pick up an object, but he isn't doing that, but he is reaching. So you might then bait his hand with food, and so he learns to bring his hand to his mouth in order to acquire the food. Then you ask him to reach out and grasp the food, and you support his wrist, and then bring the food to his mouth, which is a reward, and he's hungry.
Mm-hmm.
Then you don't support the wrist. Finally, you put the piece of food on a flat board, and he has to reach down and pick up the food. And then you put it in a shallow well, and he has to pick it out of the shallow well. These are all successive approximations. It goes relatively rapidly.
And during these successive approximations, the unaffected arm is being constrained.
Don't have to constrain the unaffected arm.
Okay.
Can do that just on the basis of reward. In effect, you're forcing the animal to do improved movement in order to get a reward. In monkeys, it's food, or if he's thirsty, a drop of liquid. In human beings, it's praise.
Mm.
And also because the human being wants to improve his movement, and that's inherently reinforcing. Okay, so we have these two techniques that are capable, we found, of converting a useless diaphragmatic limb to a limb that could be used extensively. Parenthetically, I might add that if this is true, then the Sherringtonian reflexological principle could not be true. And that's what we were after. But it occurred to me after a period of time, and I'm embarrassed to say how long it took, that if this worked with monkeys after single limb deafferentation, how about stroke in human beings? Because stroke affects one side of the body. So that if...
Sorry, go ahead, continue. Sorry to cut you off.
No, what were you going to say?
I was going to ask if at this point, did you realize that what was going on with the monkeys was learned non-use, or was this still too early?
That's where learned non-use comes from.
Okay.
And it was a matter of fact, and I'll get into learned non-use later, if you will.
Yes.
That's aggression. But it was the formulation of the learned non-use theory that led to the prediction that these techniques would be applicable to human beings after stroke, but not only after stroke, but after other neurological injuries like MS, TBI, cerebral palsy, not only for the arm, the upper extremity, but for the lower extremity. That's the initial, very long phase of the research. So when I got here to the University of Alabama at Birmingham, which is abbreviated UAB, I got here to UAB in 1986, I took the learned non-use formulation seriously and tried to apply the same techniques that we had used with the afferented monkeys to human beings after stroke. We took a group of chronic stroke patients. The average time since stroke onset we call that chronicity, was 4.5 years.
And these were individuals who had no use of an upper or lower extremity during that time. They were
even from little or no use to greatly reduced use. The people who we worked with had, when we quantified it, 12% of the amount of use of the more affected extremity in everyday situations compared to before stroke. So that's a very substantial deficit. That's average. And we applied the same two techniques that we had with monkeys. We did that for 10 consecutive weekdays. We started out with 6 hours a day. Now we use 3.5 hours a day, and it works just as well. We've also got other reduced protocols with reduced hours a day. And if you work things right, which might be a little complicated to go into, we call it a transfer package, you get just as good results. So,
and you don't have to starve these people either, right?
No. We keep them well fed. And
So as you mentioned before, the difference with the experimental monkeys and the practical use of the therapy with patients relies on human motivation and ability to recognize like a verbal reward, or is that accurate?
That's accurate. But first, let me go into the variants of CI therapy. I've already outlined them: stroke, chronic stroke, TBI, traumatic brain injury, MS, cerebral palsy, starting at 1 year of age, going throughout the age range of the upper extremity and lower extremity, arm and leg. There are other variants. We've worked with a variant of CI therapy for focal hand dystonia in musicians. This is fairly not well known among musicians, where when you practice a lot, and musicians practice a lot, like any instrument, they stop being able to make individual movements of the finger. You move one finger and another finger moves, and they can no longer play their instrument. That's called focal hand dystonia in musicians. We also worked with phantom limb pain in upper limb amputees. These are variants. So if you look at them in the clinic or laboratory, they look very different. But exactly the same procedural techniques are used. Conceptually. They have to be modified to be appropriate for whatever function that is now impaired, whatever that function is. Okay. It might be worthwhile mentioning how this seems to a patient. And I remember the 5th patient that we had, I remember him vividly, because this happens very rapidly, just like in the monkeys. They start using the impaired limb, the stroke-impaired limb, on the first treatment day. And usually the largest changes are early in treatment. So after the 3rd or 4th day, this patient said plaintively, "You mean I could have been doing this ever since my stroke?" I lied. I said, yes. It isn't quite that simple. When we talk about learn NonUse, I'll tell you why it isn't that simple. But I said, yes. Certainly after 2 months, he could have been doing it. He was 5 years post-stroke at that time, at that point. And it was a question of intense frustration and regret of all of the useful living that he could have been doing during that interval.
Mm-hmm.
And that, for me, encapsulates CI therapy because it goes off very rapidly.
Mm-hmm.
Okay.
Is there an upper limit to how much can be regained with the therapy? Is it possible to get full mobility back from a limb?
We're not sure.
Okay.
In some cases, yes. And NIH doesn't fund long-term therapy, unfortunately. They have a rule of thumb. But we have pilot data from stroke patients, CI aphasia therapy patients, and now from our pilot subjects with CI cognitive therapy, that if you do something called the transfer package, which is a set of techniques designed to get a person to focus attention on what they're doing outside of the treatment setting. Traditionally, physical rehabilitation focuses on what's going on inside the treatment session.
Mm-hmm.
And they make certain gestures at what's going on in the life situation. But it's the life situation that's important to the subject and their immediate family and society, not what's going on in the treatment session. That's what the therapist has best control over. But that isn't what makes a therapy effective. If a therapy just works in the treatment center and it doesn't generalize or transfer to the life situation, then why bother?
So in a somewhat crude example, perhaps, if a person is participating in CI therapy for a right arm that has lost mobility, you would encourage them in their daily life outside of therapy to be using that right arm to, say, brushing their teeth or making a sandwich, and that will in turn continue to improve the use of that limb.
Exactly. And we do that formally by a set of techniques called the transfer package, where we focus a person's attention on what's going on in the life situation. We have them recorded on sheets which we give them with check-off components and room for comments about problems. They bring it in when we discuss it, and we do problem solving with them to overcome perceived difficulties in carrying out what they've done in the laboratory to continue doing that in the life situation. Then we give them homework exercises, and after the and we check on whether they've done them and whether they have problems with it. We've got a set of 30 activities of daily living, which we ask them about every day. And after the end of treatment, they're given a set of exercises to carry out for a half hour every day. And we contact them once a week for the first month and once a month for the first year. And when we do that, the people keep improving. We did this with two people who came in with substantial language deficits. They were speaking in sentences of one or two words. We used CI aphasia therapy for 3 weeks, not 2 weeks. And then after they went home, they had a set of homework exercises, and we checked on them once a week for the first month, and then once a month for the next 2 years. And at the end of 2 years, both of those people were back to virtually normal speech from substantial impairment. With CI cognitive therapy, speed of mental processing, speed of cognitive processing, we've only gone 6 months up to this point because we're still doing that work now. And in each of, we get a very substantial improvement. I'll tell you about what that is in a moment. But it's only half normal. But if you keep checking on them and they keep working on it, they will keep improving.
So these are exercises, I'm imagining, that require the person to focus on their area of deficit. So if it's someone who has problems with their memory, for example, you would be requiring them to do memory drills. Is that accurate?
We haven't worked with memory as yet.
Okay.
We worked with cognitive processing and remembering appointments, remembering to take their medication, starting conversations, picking out their clothes for a day, making out a shopping list, picking out a name from a telephone book and calling and initiating a conversation, going out. We stopped working with the COVID lockdown, but before that, these people were socially isolated. And part of their homework was to go out to church, to go shopping, to go to department stores and interact with salespeople and cashiers. And as they did it, they got better at it. In what you wrote me, you spoke about the principle of use it or lose it. That's very much the case with CI therapy. CI therapy makes use of that principle. It insists that the patient use the diminished faculty, and as they use it, they get better at it. Can they improve back to normal? I'm sure that not all people can. But I've already seen that some people can. And if you keep working on them in this indirect way after the end of treatment, virtually everybody will get better. Everybody that we've worked on gets better. Not back to normal, but then we haven't worked on them long enough. They're only the 2 CI aphasia therapy patients that we've worked with for 2 years. We haven't been able to get funding to work with people long term.
Perhaps this is a good place to talk about learn NonUse, since we're talking about, in the example of people who have been socially isolated, it seems that isolation would result in just further unlearning, if you will. Would you mind describing what learn NonUse is and how that relates to this whole idea of regaining control of certain functions?
Sure. There are 2 related ideas. One is overcoming learn NonUse, which I will describe to you in a moment. And when you do that and increase the use of a disused faculty, what happens is the brain starts changing. There's brain plasticity gets enlisted, and the brain starts changing in very substantial ways. So CI therapy operates in terms of 2 related mechanisms: overcoming learn NonUse and cortical plasticity. resulting from overcoming learned non-use. Let's start with overcoming learned non-use and go back to the case with monkeys.
Okay.
Consider what happens with a monkey. You deafferent one forelimb. The monkey stops using the limb. In order to not be rendered helpless, the monkey starts using compensatory strategies. That is, he uses one forelimb to carry out the activities of both, so that when he ambulates, when he walks on all threes, and he can go pretty fast. He climbs with just one forelimb, and he can climb. He picks up food objects with one forelimb. He avoids threats with one forelimb, and that works. It doesn't work as effectively as using both forelimbs, but it works. It's rewarded, and in behavioral psychology, we say, because it's been demonstrated in thousands of experiments, that rewarded behavior is strengthened. And if you're rewarded enough, it's overlearned and suppresses other forms of behavior. Now take the monkey. The deafferented one forelimb. He can't use the deafferented forelimb. There's a reason for this. When you have a substantial neurological injury, like deafferentation of one forelimb or both forelimbs in monkeys, or stroke in human beings, you get a neural defacilitation, that is, a loss of central nervous system excitability, that is called diaskesis. It's called a shock phenomenon. And the organism, whether a monkey or a human being, will recover from that after a period of time. But it takes time. Weeks to months in monkeys, longer in human beings. And they will continue recovering function for up to a year. But during this initial period, when there is loss of neural facilitation and excitability, diaskesis, the monkey can't use the limb. He can only use the intact limb or the limb less affected by stroke. And so he uses that, and that's at least partially successful. It's rewarded, and use of that extremity alone is overlearned.
And by overlearned, you mean in some form, I guess, that program is beginning to take up more space in the brain and starting to push out the space that the other limb had taken up.
That's exactly what happens. And in the last few years, it's been demonstrated that overlearning involves substantial cortical changes. And these cortical changes are associated with the suppression of use of the more affected arm. So there's a behavioral aspect and a neural aspect to this overlearning. And it suppresses use of the more of the less affected arm. So that months later, after spontaneous recovery of excitability has occurred, and the individual, monkey or human, really could use the affected extremity, it just doesn't.
Mm-hmm. I have a question that might...
that's where therapy comes in.
Yes. I have a question that might be a little unrelated, or it is totally related, but might take us off the line of the thread here, but I'm going to ask it anyway. And this might be a silly question, so excuse my layman's background, but...
I'm silly now.
When you're learning something, you are increasing the amount of space in the brain that program is taking up. Obviously, overlearning.
Yeah.
Overlearning.
Mhm.
So is it possible to, the more you learn something, does it in effect make it harder to learn other things? Or is it a situation where...
Yes.
Yes.
That
And this could go ahead.
doesn't prevent it, but it makes it more difficult.
Okay.
That's what overlearning does. Mm-hmm.
So how do you not overlearn? What is the key to not overlearning something and to allowing your brain?
To prevent overlearning, you would start working with a person immediately after stroke and keep working, inducing him to use the more affected arm to the extent that he can more and more. And as spontaneous recovery occurred, they'd be able to use it more and more until they used it to the maximum that they were capable of. At which point, you'd start getting cortical reorganization, brain plasticity, that might take the person to a new level so that they might be able to recover normal function.
Mm-hmm. And learned NonUse is something that doesn't require necessarily a physical injury or something like that to occur. It can happen just from not using a limb, right? Like before we got on here, we were talking about individuals who are trapped in hospital beds for a long time and lose certain functions. So this is something that can just be developed through apathy.
That's right. Apathy, NonUse, whether it's induced by the treatment conditions or depression.
Oh, depression.
Yeah.
And would that be...
frequently become depressed? And
that is affecting cognitive functions?
Eventually, yes, it does. So that chronic stroke patient will sit on a couch and have their caregiver, spouse, whoever, serve them. And they don't get up. They could get up. They don't get up. They become more and more mobile and less functional. Eventually, cognitive function becomes involved. And
there goes the decline, right?
And you get a decline. CI therapy works for all of that.
I mentioned to you a program that I have been practicing on and off for a couple years now that involves various ambidexterity training, such as like writing and cursive handwriting with your non-dominant hand. There's some other exercises such as bouncing a golf ball off a rubber mallet with both hands. And I've noticed when doing those exercises that it calms my brain down. It seems I become less anxious. I also seem to focus a little better. Is this something that you found to be true in your work with CI therapy, that it has downstream effects in other areas of the brain?
I think it's the same thing. It's well known that you can convert a right or left dominant person into an ambidextrous person through training, through use. Mm-hmm. You increase the use of the non-dominant arm or disused function, and it becomes more useful. And the person becomes ambidextrous, as has been known for a long time. It's the same principle. Mm-hmm. You lose it or lose it. And when you start using it again, and you overcome learned NonUse, something else that's equally important occurs. As you increase the use of the limb, you get a change in the brain. And we have demonstrated, and other people have demonstrated, there are now well over 100 experiments in human beings after CI therapy or after CI therapy models in animals, mainly rats, that you get very substantial changes in the brain. In Europe, where I was working 3 months a year, I set up 4 clinics in Germany. In 2 of those clinics, we first demonstrated functional brain changes. That is, with Joachim Liebman, Wolfgang Miltner, and Cornelius Weiler, we showed that after 2 weeks of CI therapy, the amount of the brain devoted to innervating, mediating movements of the more affected arm doubled. The cortical representation of the arm doubled in size. We demonstrated that with one technique in Jena and with Joachim Liebert and Wolfgang Miltner, and with Bruno Kopp and Hertha Flor at Humboldt University in Germany with EEG source imaging. We used transcranial magnetic stimulation source imaging, to be technical for a moment. We call this functional brain changes because they have to do with recording and demonstrating changes in the excitability of brain tissue. And we call that a functional change. What we found at UAB, when I stopped doing research in Germany, and I continued working here at UAB, but when I moved over from doing the brain research from Germany to UAB with Jitendra Uswate, who has collaborated on virtually all of this work, and a graduate student of ours, the name will come to me in a moment, that CI therapy within 2 weeks produced a very substantial increase in the amount of gray matter, motor areas of the brain on both sides of the brain, and also an increase in the integrity of white matter tracts, again on both sides of the brain. Now, we did this in stroke patients, MS patients, TBI patients, and cerebral palsy patients. All of this is published. One thing that I've left out is what kind, and we do all of this therapy at clinics that we have here at UAB for adults, and with the Associated Children's of Alabama, which is very close by, for our pediatric patients, pediatric CI therapy. As I said, we started out with patients who used the more affected arm approximately 12% as much out in the real world as they did before stroke. And after 2 weeks of CI therapy, they were at 52% of the use of the more affected arm compared to before stroke in the life situation. That's almost a 5 times difference. But as I said, if you keep on working with the patient, the 2 patients who we worked with for 2 years kept improving so that they were virtually normal in speech. For cognitive function and movement, after 6 months, they are substantially improved compared with immediately after treatment.
And I just guess I want to stress that the continuation of these exercises is vital, even after some improvement has been made. I watched the video with you and the Dalai Lama giving a presentation talking about your work, and that was one thing you stressed to him was that even after small improvements have been made, the person is urged to continue going until larger and larger improvements are made. And this is because eventually, upon stopping the treatment, there will be some decline. Is that correct?
No. If you do work with them, after 1 year, there is no deficit.
Oh.
Or depending on the study, in one study we had a 20% decline. In other studies we get no decline, whatever. And don't do anything with them.
Is that? Do you think that's because the people have learned to use that function in their daily life? They're no longer,
And it's inherently rewarding, so they continue doing it. But you can get them to keep improving by keeping them at a distance, shaping them, and asking them to keep improving slightly. The Dalai Lama was very interested in this, but he was interested in it because he was interested in the capacity of the brain, of the central nervous system, for modifying itself or being modified. And he's very interested in that because he feels that that's what meditation does. And there are many experiments indicating that that is what it does. And by the way, I strongly recommend meditation. Yes. It won't improve your motor deficit, but it will certainly improve your emotional state, your state of mind, and your state of health.
Are you a meditator?
Yes, I am.
That's excellent. Yeah, I meditated before getting on here with you to try to improve my cognition in some way.
I'm sure it did.
Yeah. So is that something, do you encourage your the people doing CI therapy to also seek these other forms of these other modalities?
I don't, but that's not what they're. First of all, if I did that for the experiments, that would contaminate the experiments because the objective is to demonstrate the effect of CI therapy, not the effect of CI therapy plus meditation. Mm-hmm. And if I did that with patients who insurance was paying for or were paying for it themselves, that isn't what they would be paying for. But I always encourage people to meditate with their own, as you know, peace of mind. But peace of mind is just one thing because so much of illness is stress related. When you reduce stress and going back 4,500 years to the Rig Veda, to the Vedic literature, the mechanism that has been given for why CI therapy works so effectively is stress reduction. And the ancient Hindu scholars had what they conceived of as a conceptual nervous system. And they conceived of stress as actual physical nodules at the interstices of a cobweb of nerve fibers. I don't know how nobody did dissections then, and I don't know how they understood, and their conceptual nervous system is very different than the way we understand the nervous system today. but it has some similarities, and they've spoken about the physical release of stress as the mechanism by virtue of which meditation works. In the Rig Veda, it talks of stress, and in the Bhagavad Gita, which is like the last of the Vedic literature, it talks of stress as being a fire that consumes the sources of ignorance. And what they mean by ignorance is stress. It consumes the sources of stress. And when they say consumes, they literally mean consume. They mean it is a fire that consumes, literally leads to the disappearance of physical nodules of stress in the nervous system. And as a result, the person becomes healthier, they live longer lives, and that's demonstrated. They have fewer strokes and other cardiac events. It's reduced 90%. There's controlled experiments along those lines, and it increases in longevity and decreases in asthma and weight loss. I've been in large groups of meditators, thousands of them, and you almost never see a long-term meditator who's overweight. And now there's at least one controlled experiment where by meditating for 3 months, there is a loss of weight.
What is going on there that is causing that to happen? Those two do not seem as though they should be related to me.
Reduced stress.
Reduced stress. So the stress is keeping it from your body, from your metabolism working? Is that
right?
Yeah.
Keeps out the stress hormones and the stress metabolism, the effect that stress has on the metabolism, which leads to a healthier individual and happier individual. So what a person notices first is they feel calmer. Mm. But if they continue meditating, they become healthier. Hmm. I could go into that literature. But, I don't know whether that's what you want to hear about.
I mean, it's definitely an interest, so I'm fine with it. If it seems like a topic that you're excited about, and I think we've covered a lot of the bases that I wanted to cover with the CI therapy. So by all means, what does some of the most notable literature say that you would feel like sharing?
Well, I do a form of meditation called transcendental meditation, or TM. The most common form of meditation these days are meditation exercises based on Buddhist meditation, like mindfulness meditation, other forms of concentration meditation, loving kindness meditation. That is a form of meditation that the Dalai Lama is particularly partial to, where you focus your attention strongly on objects or people.
Yes, I'm most familiar with the loving kindness and the mindfulness. I don't think I've explored too deeply into transcendental meditation at all.
Well, transcendental meditation is mantra meditation, where you have a silent sound and you repeat it silently over and over and over again until hopefully at some point you lose the mantra and enter into a state called transcendence, where the mind is awake inside, but there's no object of knowing. so that you have a knower, a person, in the act of knowing, but no object of knowing. You're deep inside. It's expressed by the word Sat-Chitananda, which is really three words. Sat, the knower; Chit, the act of knowing; and Ananda, that which is known. And when you're in transcendence, what you know is Ananda, or bliss, right? So the objective of transcendental meditation is the experience of bliss, or the experience of nothing, which emotionally, when you're finished with it, is an experience of bliss, happiness. So that the Dalai Lama's monks are very happy people.
Mm.
And long-term meditators are very happy because they've dissolved the stress in their nervous system. Examples of the effect. There is a community of meditators in Fairfield, Iowa, built around a university, which used to be called Maharishi International University after the founder of the movement, Maharishi Mahesh Yogi. And it's now called something else. But anyway, a community built up, and there were then 3,000 members of the community and students who were covered by Blue Cross Blue Shield in a separate contract. And 1 year, Blue Cross Blue Shield returned 1/3 of the money that was paid in to the meditation community. And the reason was that they made 2/3 less of medical services, and they returned half of that. Okay, the point is that this was objective. This wasn't an experiment. It was just returned by Blue Cross Blue Shield. And it turned out that there was 90% fewer hospital days, 80% less heart attacks and stroke. NIH got a hold of this at a period when cardiac disease was a priority, and funded a lot of TM research on cardiovascular disease. And you got all sorts of things happening. You get in atherosclerosis, you get a thickening of the walls of the artery, the two inner walls, the antima and the media. After 6 months of CI therapy, there was a measurable decrease in the thickness of the antima and media bands.
After the CI therapy, or after
therapy group is controls. It's after 3 months or 6 months. You have a decrease in hypertension, borderline hypertensives into normal tension. You get an increase in longevity in people with hypertension at the end of 7 years from cardiovascular events. Okay, one of the criticisms of the Fairfield, Iowa data, the Maharishi MIU, Maharishi International University data, was that maybe people who are already healthy are the type of people who start to meditate and become long-term meditators reasonable, except that a large number of the people who began to meditate started to meditate to avoid, to get out of the drug culture. They were using drugs and they wanted to kick their drug habits, and they began meditating instead. And meditation has a large demonstrable effect on reducing addiction to alcohol, to narcotics like opium, to amphetamines and cocaine, barbiturates, and cigarettes. Though interestingly, alcohol and cigarettes are more difficult addictions to kick than opium and methamphetamine. And this is well known. It's less dangerous to detoxify from addiction to narcotics compared to addiction to alcohol. The most difficult at all is cigarettes. And you see this in the TM literature, where you have a huge decrease in tendency to drink. I'll tell you a secret.
Please do. All ears.
Before I began to meditate, I was a heavy drinker. And it was starting to have an adverse effect on some areas of my life, professional life, not my health or my marital interaction. I began to meditate because at that time I was trying to develop a biofeedback technique, which is now called thermal biofeedback. That is, the question was, this was in 1970, can you train a person to learn to self-regulate their tissue temperature, like the hand temperature, warm their hands, cool their hands? It hadn't been done up to then, and we started to try, and for the first year we were unsuccessful. So that on the basis of a theoretical article written by a mentor of mine named Neil Miller, he said one of the reasons might be, it's a complicated story and I won't go into it, that it has to do with paralyzed rats and these were a series of experiments. And it was much more difficult for human beings to self-regulate their autonomic functions like heart rate and blood pressure and tissue temperature than it was for paralyzed rats to do so. And Neil Miller said, well, maybe the reason was that after paralysis with the chemical agent D-tubocurarine, it had quieted their nervous system. And maybe the thing to do is to train human beings to meditate, to quiet their nervous system, and they'll be able to learn to self-regulate more rapidly. Well, Neil Miller was my main mentor. I had several others. And so I took this seriously. And I had a grant from the Department of Defense, DARPA, the Defense Advanced Projects Agency. And I took myself and a research associate down to the TM Center with a check from DARPA and paid the initiation fee to learn to meditate. I learned to meditate. And so having learned to meditate, I now knew how to carry out the meditation without blowing the meditation or interfering with self-regulation. We had them meditate first, quiet the central nervous system, and then do the same self-regulation technique that we've used before. It's not so simple, but that's the way it wound up. That didn't work.
It didn't work.
It didn't work, and I wasn't. Neil Miller was a major scientific figure, and I wasn't the only person who read that article. Other people tried other biofeedback techniques, and it didn't work. But I had begun to meditate. I had learned to meditate, not because I wanted to meditate, but just because I wanted to learn how to do the biofeedback experiment.
Which didn't work.
Which didn't work.
Yeah.
And I had been meditating for 3 weeks, and I was about to stop. My wife is an opera singer, and she was touring down under at the time in Australia and New Zealand. And so I was working on renewing 2 grants. I was very busy, and there was no monitor on my behavior. One night, late at night, I got into the turn lane to my building, and I was sitting there waiting for the light to turn, and I realized that I had no desire whatever to have a drink. And then I realized that without realizing it, I hadn't had a drink for 5 consecutive days, and I don't know how many years it had been.
Wow.
Since I had gone 5 days without having a drink, and this was with no desire to stop drinking. I just had no desire to drink. And I said to myself, and I quote, "Now, that is a datum. My language had already been corrupted by being a scientist for too long." And I said, "Now, that is a datum. So I will continue to meditate." My wife came back from tour. She was the Metropolitan Opera at the time. Came back from tour. I was in Washington, D.C., and I picked her up at Dulles Airport, and in the long drive in from the airport, she said to me, "You've changed."
Wow.
"What is it?" And I said, "I learned to meditate." And she said, "I'm going to learn to meditate also." Now, we had been drinking buddies, and within 3 weeks, she had stopped drinking.
Wow. That's incredible. Is there, I know that addiction has a lot to do with the release of chemicals in the brain specifically, but is there something similar to the theory of not learned non-use going on when you're kicking a habit like that? As in I'm not sure if addiction takes up real estate in the brain at all.
There are theories and experiments that demonstrate that there are physiological changes that occur brain as you become addicted.
I'm just wondering if behaviors like, walking into your apartment and first thing you do is grab a beer. I mean, that is a program in your brain that you need to.
First of many.
Yeah.
That's a factor. That was a factor. But I was busy. My wife wasn't there. No monitor on my behavior. And without being aware of it, I had just simply stopped drinking. I wasn't addicted to alcohol.
Okay.
But drinking had become a problem.
That's a fascinating story. I'm going to keep meditating. So were you, I mean, we're at the end of our time here now, but I just wanted to say thank you for your time and for sharing your insight with me and going beyond the CI therapy we had originally talked about discussing here.
It's my pleasure.
Yes.
aside from getting married to the wonderful woman to whom I married for all these many years, the most important event in my life was learning to meditate.
How many years ago did you say that was?
50 years ago.
Wow. And was that the initial meditation that you had learned was not transcendental? It was, I forget.
Transcendental.
Oh, it was transcendental. Okay. The thing I like about mindfulness meditation is that it is something that can be called upon without having to make a noise. You know, if you're in the middle of an interview, for example, you can kind of check in with your breath, do the same kind of things that you do in a mindfulness meditation. So I don't know if those kinds of theory or that same application is possible with transcendental meditation, but I'll have to look into it.
No, it's not.
Yeah.
But, and that's good.
Mm. Different tools in your tool belt, I guess.
Sorry?
It's just about having different tools in your tool belt for different jobs, right?
I'm not sure. 2,500 years ago, Patanjali, in the Hindu tradition, talked about one path. You start with one kind of meditation, and you continue with one kind of meditation. You don't experiment around. That is characteristic of New Age meditation. Try one, and then try another kind of meditation, and you dabble. The idea is you pick one kind of meditation and you stick with it, one path.
So far, that's what I've done. I've tried metta, loving kindness meditation, but it didn't stick with me. So I typically just do Vipassana.
Oh, this isn't experimental. This is what Patanjali said. It's what I've done. But it doesn't mean that if I had learned the second kind of meditation, I wouldn't be in a better state than I am now. Mm-hmm. Or anybody else. It's just, this is what I've done, and this is a traditional approach to meditation, one path. And I might just mention that when this COVID lockdown is passed, all of these forms of CI therapy are available here at UAB.
Okay. I'll make sure to note that in the intro as well. And I'll also provide links to you and your work in the show notes for people to check out if they want some more.
Thank you.
Thank you very much, Dr. Taub. I really appreciate it.
My pleasure.